advances in joint replacement and rapid recovery. So dealing mostly with hip and knee replacements. So hopefully this is interesting, and we'll have time for lots of questions at the end. So if you guys have them, just hold on to them, and then we'll spend a lot of time at the end answering whatever questions you might have. So I don't have anything to disclose for this talk. About me, so I'm actually a Bay Area native. I came from San Jose, went to Bellman for high school, and then I went across the country to Duke for undergrad, and I've pretty much been at UCSF for the rest of my time, except for 1 year back in North Carolina for fellowship in joint replacements in North Carolina. But it definitely follow the motto, if you can stay forever. I've been here and I don't want to leave. So an outline of what we're going to talk about today, just kind of the burden of disease and epidemiology surrounding joint replacements, the basics of hip and knee replacement, and then also what's improved over the past decade in terms of not only the longevity of the replacements, but pain management, the acute hospital stay, some things like DVT prophylaxis or blood clot prophylaxis, and then just reducing risk associated with joint replacements. So just a little question for you guys. What do you think is the most common inpatient surgery performed in the U.S. today? So there's 2 joint replacements on there, and then we got some stents, percutaneous coronary angioplasty stents, decompressing the spine for spine stenosis or appendectomy. And it's actually hip. You guys think hip? Yeah, knees. So it's knees. Knees are number 1, and hips is actually number 4. So I got 2 of the top 4 that I do every day, and stents are number 2, and laminectomy, so spine disorders number 3. So this is a super common surgery that's done in the U.S. That's a little bit of older data. But arthritis in general is a major cause of disability for U.S. citizens, and about 22% of people have arthritis. And it costs the U.S. a lot of money, not only for healthcare-related costs, but also for time if you consider lost work or things of that nature associated with arthritis and the inability to perform jobs. And you can think of it as up to $2,000 per person in the U.S. Is the cost of arthritis every year. The number of joint replacements that's done every year is going up rapidly. These charts are actually from 2007, but we're right on track with those curves, on pace to meet about 3.5 million total knees done a year and about 570,000 total hips done a year by 2030. So we're right on pace with this, and that comes from a couple of reasons. There's increased utilization because we are an aging population in general, so more people are getting into that age range that are getting arthritis, but also the indications for arthroplasty or joint replacement have been broadening a little bit. So with improvements in technology, we're a little more we allow younger patients to have it done than we might have in the past because the successes have been so good. And then we also have in the younger population, increase in obesity, and arthritis is definitely associated with obesity. So with increasing weight, you get increasing force on the joints, and it just doesn't do good for the cartilage. So why do we replace a joint? I think the overall kind of umbrella term that you can think of for arthritis is for arthritis. That's what a joint replacement is for. But arthritis is a very broad category, so it covers a lot of different things. And at its most basic, it just means joint inflammation. And joint inflammation, you can then stepwise go to joint pain, as what arthritis is. But it's really a disease of the cartilage, so the ends of the bone. And as the cartilage degenerates, it causes pain. You can get limping, you get swelling in the joint, you get stiff, or you lose your motion, and eventually you can start even getting deformity from that as a result of that cartilage being lost. So these are some x-rays of just the kind of deformity you can get. So on my side of the screen here, you can see a patient who, this is a knee, this is their leg, and you can see how angled their leg is when they're trying to stand upright because they kind of are losing the bone on the outside of the knee. Or this is a hip, so this is sort of a normal-ish looking hip here, and then if you look at the other side, you can see that they've lost a bunch of bone and they're kind of losing the shape of their hip. So one way to think of arthritis is kind of like if you think of the end of a bone as a road. We all start off with kind of a smooth, well-paved road. The cartilage is nice and smooth. As we get a little bit of damage, you can start to get cracks in the cartilage or cracks in the road. Eventually those cracks can spread and become potholes where you actually have exposed bone as opposed to cartilage on the end of the bone. And when you get really bad, it kind of just falls apart. And this is really like what a joint can look like when you go in there, and you've kind of lost all the cartilage. So arthritis, as I think we all are aware, because we all know someone who has joint pain or arthritis, but it definitely can really affect your quality of life. People lose their independence because of it, because they're not as mobile. Just simple things like just walking are difficult. And as such, it affects people's mental health as well. There's definitely a link between immobility and arthritis, severe arthritis, and depression, and other things that can get better if we're able to reverse those things. And then also family life, sleep, all these things. And anyone can get affected by arthritis. It's not a disease of the poor or the rich. It's not a disease of specific countries. It's really anyone can get it. It's kind of a universal problem. So overall causes of arthritis, things that can cause the cartilage to break down, these are the major categories. When you think of the most common people get, it's called osteoarthritis. It just means arthritis of the bone. And the best way to describe this is kind of wear and tear arthritis. So if you've been really hard on your joints, that might be a reason that you have it break down. There's probably a genetic component, or there most definitely is a genetic component. It runs in families, but there's also people who have no family history of it who can just wear out their knee or wear out their hip. So the exact reason why someone might get it, someone not, we don't really have a good explanation for that in terms of osteoarthritis, but we know it is about a quarter of the population can eventually get that, especially as you get older. Other types of arthritis, inflammatory arthritis, this is things like rheumatoid arthritis or psoriatic arthritis, which are more of autoimmune diseases. They can cause cartilage to break down. You can have an infection in the joint that causes the cartilage to break down. Another common thing that we treat is what's called osteonecrosis, or the bone actually dying, and that can be a result of loss of blood supply to the bone. And we'll talk about that in a second, but a lot of different reasons or ways that can happen too. And then there's a smaller group of people who are sometimes the most disabled, are the people with childhood or developmental diseases. So this x-ray is a patient who I've actually replaced both their hips now, but this side is more of the wear and tear arthritis on this left hip, which is probably the result of him using that leg almost exclusively because his right hip when he was born was dislocated, and so it developed in the wrong position, and as such it's kind of never seen the normal stresses, never developed properly, and is quite painful for him. In terms of how do we diagnose it, there's kind of two categories. You can have clinical arthritis and you can have radiographic arthritis. Radiographic or X-rays, the best way to tell if someone's having arthritis is to look at the bones on the X-ray, and we're kind of inferring the cartilage through an X-ray. So an X-ray is really good at seeing calcified bone. It's not very good at seeing soft tissue. So what we do is we're kind of extrapolating what the cartilage is looking like based on the space between the bones. So if you look at this X-ray here, you can see this black space between the bones. We're inferring there's cartilage. This is a fairly normal looking X-ray. What you can see on this one is that you've actually got some narrowing on the inside of the bone, on the inside of the knee, and that can be from the loss of cartilage. It's kind of not holding the bones apart anymore. What's interesting is this is the same patient, and this shows that how important the technique for radiographs are. This is the same knee, same patient, same day. One is just an X-ray that sometimes a primary care office or things will get where you're not actually standing on the leg. Your leg is just there, and you can get fooled into thinking that your knee is fine. And as soon as you add some weight and close down those bones together, it actually looks quite arthritic. We generally, in terms of in a joint replacement clinic, MRIs are not very helpful for us. We don't really need them because that's not what we're looking for, and we can usually figure out what's going on based on the appearance of the bone and the appearance of the cartilage. So in general, we don't really need an MRI. It doesn't help us, and most of the things that MRIs are looking for, by the time you have arthritis, it's a little the ship has already sailed. So meniscus tears and things like that, that's just part of the problem with arthritis. If your cartilage is worn away and you're touching the bones together, your meniscus or the cushions between the ends of the bone, they're already gone. So an MRI that says you have a meniscus tear, I can already tell that based on your X-ray. I don't need you to get that expensive test to come and see me. So knee arthritis, this would be kind of a typical pattern. Is this we call this varus arthritis. So you're losing the cartilage on the inside of the knee. So you can always tell the inside of the knee on an X-ray by where the fibula is. This is the small bone on the outside of the leg. So this is the medial or the inside of the knee, and you can see that this patient has lost the space between the bones. The bones are almost touching, and that would be arthritis. So that's the radiographic picture. Now this person may have zero pain, may never have had any problems with the knee their entire life, and so it's a combination of what do the radiographs look like, and then what is the patient experiencing, or what are they having from a symptom-based perspective? Are they having that pain? Are they getting stiffness? Is it affecting what they're trying to do? At the other end of the spectrum, you can have people with very mild arthritis who have very severe clinical symptoms of pain and disability, and so it's kind of a combination of these two that we have to look into. Hip arthritis is similar to the knees. We're looking at kind of the space between the bones. This person doesn't really have a great hip on either side, but you can kind of see a space between the bone here on this left side of the hip versus on the right side. They've lost all that space. They're getting some cysts in the bone, these little dark circles. The bone's getting sclerotic. That means it's getting hard and it's responding to the bones touching as opposed to having that nice soft cartilage on the end. Again, clinical signs of the hip pain, hip arthritis are typically groin pain. So people complain of pain that sometimes is very an actual hip joint or this ball socket joint is more of a groin pain. So if I kind of, it's more of this kind of orientation of pain, sort of deep. Sometimes people will talk about a C-shaped pain kind of going around the side or in the back, but that's more hip pain. Pain is kind of down the butt or down the back of the leg, or pain on the side of the hip on the very outside. That's generally not the hip joint, and is something different usually. This is an example of inflammatory arthritis. So this would be something like rheumatoid arthritis. You can just tell the X-ray is a little different. It's more destructive in the bone, and you can sometimes get wear the cartilage in places that aren't really weight-bearing. So in a hip, we expect that the weight-bearing surface, or this kind of top portion when you're standing, is where you're going to get most of your wear and tear. If you're kind of wearing out the inside of the hip towards the middle, that tells us that it's not really a pressure phenomenon or a wear phenomenon. It's more of something's eating the cartilage away. So in this patient, their own immune system is attacking their cartilage and eating the cartilage away. This is kind of a little bit of a dying thing from a joint replacement perspective in orthopedics in general, is a lot of these autoimmune diseases and inflammatory arthritis are much better treated with some of the biologic agents now, so this is kind of a less common occurrence than it might have been 10 years ago. Another thing we treat is people that have had prior trauma. So if you've had a fracture, sometimes that, no matter how well it's put back together, sometimes the cartilage was injured at the time of the injury, and so you can have eventual breakdown. Or in these cases, this patient with the pelvis X-ray there on my side, they tried to have fix a fracture around their socket, around the
Yeah.